Right. So yes, today's session will be focusing mostly on AI and medical imaging and omics, interpretability and clinical translation deployment, which is like a core part of our community's mission. It brings us right to the cutting edge of our community's focus areas like medical image analysis, explainability, and interpretability. We are very thrilled to host such a leading expert to help us move this conversation forward. We will be having a very dedicated Q&A session immediately following the talk. So please drop your questions in the chat as they occur to you, and I will be moderating the Q&A segment. You're also free to unmute yourself to ask questions at the end. So with that context set, I will now move forward for the reason we are all here today. I'm absolutely thrilled and privileged to introduce our distinguished guest speaker today for Dr. Satish Viswanath. Dr. Viswanath is a perfect fit for our community's mission. Professor of Biomedical Engineering and Pediatrics at Emory University. He's also a research scientist at the Cleveland VA Medical Center. He also serves as an associate editor and board member for 9 leading journals, and also as an area chair for 3 medical conferences. The primary focus of his research group has been developing artificial intelligence, radiomics, and machine learning schemes, which is applied to computer-aided diagnosis and detection, along with the treatment response evaluation, which is across pediatric conditions and colorectal and renal cancers. His group has recently published an impactful work towards equitable healthcare at MICI 2025, which addresses bias in medical AI, which is quite interesting. So please join me in welcoming Dr. Viswanath, and yeah, the floor is yours. You're actually on mute.
There we go. Finally managed to get a click button. All right. Everyone should hopefully be able to hear me now.
Yep.
All right. Great. Thank you very much for that kind introduction. Thank you to Lima and Cohere Labs for inviting me to give the presentation. So I'll get started by kind of setting the stage, why we're here, what the focus of this talk is going to be, and then we'll go through a few different exemplars of that area. So as you can see, you got a lot of interesting terms that I sort of came up with when I was designing this talk. So hidden signatures, imaging AI, patterns, predictions, precision medicine, and so on. So we'll start out with all of this with kind of just setting the stage about where we are. We're talking about healthcare. We're talking about AI, and I really like this particular phrasing of this topic, which is it's an overnight success, which has been decades in the making. So as you can see this kind of predictive AI, deep learning, generative AI. You can see this kind of exponential increase in the interest and publications. You can also see that in the kinds of devices that are being approved over time. This is FDA approvals. You can see VC investment in healthcare AI companies specifically. So we're not talking about the open AI and the like. We're talking about the earlier stage healthcare AI companies. And again, you can see the same kind of balloon happening of a lot more investment, a lot of interest in this area. And I would say over the last 2 or 3 years, in my experience, it's kind of been, we see this sea of heading showing up almost every other week. It's going to change the economy, it's going to change our work, it's going to change our education, it's going to even change war. So you see all of these different news articles, these perspectives coming out. But one of the things I realized, a few months ago is there is actually a little bit of a disconnect. So the disconnect is that if you were to actually ask people, not the researchers, but the people who are actually being impacted, versus you ask the researchers who are working in the space, so people like me, people like some of the folks on the call, you kind of see this significant disconnect between the way each of them perceives what AI is and how AI could help or how AI may not help. So researchers tend to think AI is going to benefit people's lives, it's going to make jobs easier. And as you can see, I've highlighted over here, it's going to improve access to healthcare. But on the flip side, if you ask the general population, not the researchers now, almost 60% of them, they're actually uncomfortable about AI being part of their healthcare pathway. Minority of them actually think it's going to give you a better health outcome. right? Most of them think it's not even going to make, many of them actually think it will make no difference at all. So there is this kind of gap between what we envision happening versus what people see happening. And one of the things I'm going to try to bring across in this talk is how can we start to bridge this gap? How do we start to develop AI? How do we start to develop these models so they actually start to bridge the gap and bring people from one side over to the other? So, as I mentioned, in the talk title, we have all of these ideas of precision medicine, imaging AI, and so on and forth. So I'll just define a few of these ideas for folks on this call. So precision medicine is the idea of developing prognostic, predictive tools, tailoring therapy for specific risk profiles. In other words, we have a large population of patients. How do we start to target each of them with a specific therapy? And for this, we need to know aspects such as, maybe we need a better understanding of disease outcome, of disease progression. We could try to look at predicting response to treatment. And the way we're going to try to do this is using this idea of imaging AI. So what does this mean? So imaging AI, it could span all of the areas from digital pathology to radiology and many other modalities. So digital pathology is taking slides and scanning them at high resolution. Radiology is MRI, CT, ultrasound, PET scans, and so on and so forth. So using all of this data. And then what we're going to do is we're going to try to analyze it in a few different ways. One is, as I just showed you, we're going to try and take the data. We're going to extract a whole host of different types of features from it. That kind of references the idea of radiomics. We can also try to run that through a very complex neural network model. As you can see over here, multiple layers, hidden layers, connections, and the image basically gets broken down into a whole bunch of different components in order to make a prediction. And then we're going to try to take all of this information and use it towards actually distinguishing between maybe response groups, so which patients will and will not respond, or trying to identify the risk profile, the prognostic outcome for these patients, which patients are going to have better survival versus worse survival, and maybe some of those patients need to get a different therapy so that their survival chances improve. And so the idea is to leverage all of these in order to inform this question of precision medicine. And one of the theses I have in this talk is that a lot of these are kind of hidden signatures, right? The data we're getting from radiology, pathology, and so on and forth, it is these very vast, multiple types of imaging, multiple very complex data sets. And there is information hidden inside the data set that we need to try to extract or reveal using the techniques over here. So with those definitions in mind, let's just look at some of the exemplars we're going to go through in the talk. So for example, we want to try and take all of these different measurements. We want to try and figure out which treatments are going to be effective for which patient. And one example of this is example in colorectal cancers. So, as with many other cancers, there's kind of a very standardized pathway that has been defined for colorectal cancers based on clinical trials and a lot of clinical experience, where patients get evaluated, they get treated, they go to surgery, pathology, follow-up. There's every patient is kind of going through this pathway. But there is an option here to start to build this pathway to make it more personalized. So could we start to push patients towards different follow-up strategies based on whether the treatment has worked, how well the treatment has worked? So there is about a 30% chance that a patient with rectal cancer, for example, would have a complete response. Now the tumor can completely be eliminated as a result of this therapy. But maybe they can be monitored versus other patients could undergo surgery. Right now, though, we don't have markers to try and define these different pathways. A different example is in the context of Crohn's disease. So Crohn's disease is an inflammatory bowel disease. So the bowel wall in that patient starts to get inflamed, starts to get larger, starts to constrict and cause issues as far as nutrition and pain and many other side effects. And a lot of the therapies that are available for these patients actually do have a very high failure rate. So again, we have a decision tree that we have to try and figure out. So what should a patient be recommended towards? Should they get medication? Should they be given some kind of minimally invasive intervention? Should they go all the way to get a very aggressive intervention, such as surgery, to basically take out the inflamed or the strictured part of the bowel and stitch it back up so maybe they have some relief? But these are open questions. We don't have, again, the problem is we don't have very effective markers to make these decisions. And these are some of the answers. These are some of the questions we're going to try to pose to the radiomics, the deep learning models that we're going to be talking about today. So as I mentioned up top, I said, colorectal cancers. So this is one of our, this is a study which is now a few years old, but this is one of our early efforts where we did start to determine that there are ways to extract radiomics or those features from the imaging, which can be used to identify response in rectal cancer. So here what we have is we have a whole host of patients, multiple institutions, and all of these patients, we have a diagnostic MRI scan. So this is the scan taken of the patient just at the point at which they got evaluated as having tumor, right? And clinically speaking, there's no way to actually figure out if that patient is going to respond, not going to respond, what's going to happen. And now the question is, what do you mean by response? Well, as I said, response is that the patient has undergone treatment and the tumor has gone away. So now the question is, can I figure out if a patient is going to respond to a particular therapy? Can I figure out they'll respond to a different therapy instead? So to answer that, we took this cohort of patients and we found that while clinically there was no way to distinguish them, if we extracted our radiomic features, so as you can see over here, patients on the left, who are the patients who achieved complete response, have a very different pattern in terms of the radiomics and the heterogeneity compared to the patients who did not respond, who have a very different pattern in terms of their heterogeneity. And this is a very interesting finding because this suggests that there is hidden information inside this MRI scan that we can start to quantify, which allows us to make more advanced characterization and potentially more informed decisions. We also evaluated the signature because we had multiple institutions. We said, okay, let's take one institution to build a signature. Let's take a different institution and test that signature. We found that these heterogeneity maps appear, show a similar trend across institutions. The performance is fairly consistent. You can see over here, green is our training set or the discovery set where we learned the signature, and down here is the validation set, which is where we tested the signature. Again, we're seeing pretty consistent performance. So this is on the MRI. More recently, this is, we fast forward to, last year, we actually started doing some work where we started to see if we could take the digitized pathology images and do a similar process. So here we have a patient who's been diagnosed with rectal cancer. There's a biopsy taken of the tumor itself. So that's what this looks like. And then what we were able to do is develop a pipeline and a signature that was able to identify the tumor, the types of cells present. And then what we found was that if you took this diagnostic pre-treatment pathology image and you were to kind of extract information from it, you can take that information and there are actually signatures in there which distinguish whether that patient is going to eventually respond to chemoradiation or not. So now there's an underlying phenotypic, there's an underlying signature within this pathology image that we can start to go after. And this actually incorporates information coming from the tumor, from the immune environment, from the fibroblasts, from the stromal tissue, and that's what these visualizations are showing, different cell types and the features inside those cell types. And we found very different signatures associated with patients who did respond, which is the TRG0, versus the patients who did not respond, who are the TRG3s. So we, taking all of these different types of nuclear and other types of information, we're able to then identify patients who will respond with a very high degree of accuracy. So here, this red bar over here corresponds to integrating the information from across multiple cell types in order to predict response. So we're able to extract information from the MRI, from the pathology, but then we started thinking about what we could be doing based on some of these findings. We said, okay, so clearly it's not just about a tumor region or a particular location, it's actually about the environment. So towards this, we've actually been developing more comprehensive analysis of these images and the data that we're getting from these patients. So for example, in the case of the MRI, I said the first paper that I presented, I said, well, we took the tumor region and we find these interesting maps. So, okay, great. So we can extract information from the tumor. This is kind of the axial view, which is the most standard view. But then we can also look at regions around the tumor or the peritumoral region. This has been found in many, many cancers to have a lot of relevance when it comes to identifying characteristics of the tumor. So we look at the perirectal fat, and that's what these features are showing. And then we can actually look at other views of looking at the tumor. We can look at the coronal view, for example. So coronal view is kind of complementary, or it's kind of at right angles, if you will, to the axial view. So it's giving you a different view of the tumor. So now we take this information and we extract information from there. We take this view, extract information from there as well, put all of that together, and we start to get an even more accurate predictor of response now on the MRI by itself. So over here, the different colored lines correspond to the different regions. And then the blue line is what happens if we combine information from across all of the regions. And again, you can see that this signature appears to validate from the training set to the validation set, which is very promising. More interestingly, when we started to think about this, we said, well, this is just imaging data. We have other types of data we can extract, we have available for these patients. So what if we looked at, for example, clinical variables that are being acquired for these patients? So this was a very interesting finding and kind of a theme that you see coming down, which is that, the radiomics by itself, the AI model by itself does a fairly good job, though it does have a very high false positive rate right here. But interestingly enough, you bring in the clinical variables, okay, so you take a little bit of hit on the sensitivity, but then the specificity starts to go way up. You're starting to get a much more, you see a significant drop in our false positive, false negative rates, and a significant corresponding increase in the specificity. So that suggests that there is, again, complementary information that we could be extracting and exploiting for this reason. So we've spoken a lot about radiomics, about extracting patterns from the images, but I also mentioned at the start that we can take the images, we can actually run them through neural networks or deep learning models. So one of the most one of the most typical questions is, okay, can we start to identify the regions on the image? Because otherwise we have to have someone go in and annotate them manually, which is a very laborious process. So what we've developed is we've actually developed a pretty comprehensive segmentation model, which is able to take in these MRI scans and use kind of the structure-specific context for different regions to automatically identify the tumor, the lumen, the wall, the perirectal fat. And that's what these visualizations are showing. So over here, if there is over segmentation, then you kind of see a lot of blue. You see under segmentation, you see a lot of pink. And then if the two segmentations, that is the model and the expert, kind of overlap, you see purple. And you can see this result actually looks pretty good because you see mostly purple, which suggests that the contours are pretty accurate. We also compared this model. We looked at multiple experts. So if you compare the model to multiple experts, you can see all of these bars are very similar, which means that the model is essentially performing on par with an expert, which is a good sign, which means that we are able to do this task as well as an expert radiologist could, which is great because now they don't need to worry so much about annotating the images. They can actually help us with evaluating the images, which we'll see in a later study. So we built the deep learning model. We're able to identify the regions. One of the things we noticed when we were getting these, when we were using these models in our regular research, is that we train the model, we get an output. And then when we get this output, occasionally, the ground truth that we're getting and the model there is a disagreement. So for example, over here, the pink is the output of the model by itself. And you can see that it kind of tends to miss a little bit over here. And usually, the scientists in the lab, the students in the lab, they'll get this output, and then they'll have to go in and very, slightly edit this particular annotation to get it to look a little bit better, because you don't want to be missing parts of the tumor for your analysis. So we looked at this process and we said, wait, but why couldn't we actually use that to re-inform what the model is doing? So we took these outputs, corrected them, and then passed those back into the model as a retraining step. And what we found is when we did that, now the model does not appear to miss any of these regions. It's actually doing a much better job of picking up all of these areas. And the human-informed model is not only more accurate, which you can see here with the red bar compared to the model by itself, but it's also much faster because the human correcting the model output is faster than the human annotating the model from scratch. Which is again pointing to how you can start to design these models to not only capture patterns but start to assist in the routine clinical workflow, the evaluation workflow for these images. So building on top of that, we said, okay, if we want to try and take this and extend it to other regions, how do we start to use it? So, for example, in the context of Crohn's disease, a big question is one of the major complications of Crohn's disease is a fistula or an opening, which is around the rectum, interestingly enough. And so what we said was, okay, is there a way for us to start to leverage these very large foundation models, which are trained on these, millions of images, to actually assist in annotating these images? So we take our MRI images, we identify the different regions, pass them through what is called the MED-SAM or segment anything model, and then that gives us an initial guess of where it thinks different regions are. And then we're able to take those regions and use them to inform a more specialized segmentation model that is able to then accurately identify the fistula, the wall, the muscle, the different sphincter muscles, and so on and forth. And the performance is actually better than using NN unit or a MedSam by itself. So this green bar is the performance of integrating the fistula, integrating the NN unit with the MedSam model, whereas the red and blue bars are what happens when you use just a MedSam by itself or just a unit by itself. And you can see integrating these different types of approaches is starting to boost that performance more than you would have otherwise. So continuing this idea of Crohn's disease, we then said, okay, but if we have a way to kind of characterizing what's going on with the disease, can we also start to risk stratify the disease? So here we had a cohort of patients, all of whom we had an MRI scan, and we kind of followed them for a few years to look at their outcomes. And we kind of segregated them into two groups. Low-risk patients were the patients who stayed stable. They were given an aggressive therapy, and they kind of stayed stable for up to 5 or 6 years. And high-risk patients were those patients who needed earlier intervention. So within a year, they needed some kind of surgery or escalation in order to actually have better response for their disease. What we found was that if you looked at these patients, there was distinctive signatures within that inflamed terminal ileum region on these patients. So low-risk patients tended to have a very different pattern of heterogeneity compared to high-risk patients, which you can see on the right over here. If we then take that information, we then said, okay, so we're able to extract this information with radiomics. What happens if we combine that with radiological evaluation? So this here, the Maria score, is a radiological scoring scheme for actually analyzing Crohn's disease and risk stratifying it. And what we found was that combining the radiomics with the Maria score with some of the clinical information actually allowed us to very accurately prognosticate when these patients were at risk of needing surgery or at risk of needing a more aggressive intervention. And in fact, from a clinical perspective, this actually helped us identify 100% of the high-risk patients, which is what you would need in order to be able to target them accurately. And this was more, they were able to identify more of the high-risk patients than any of the individual markers. So for example, the clinical features by themselves are not really able to prognosticate what's going on with the patients. The integrated marker is actually able to do a much better job. As you might have heard in my introduction, a lot of my work is also in the area of pediatric Crohn's disease. So for example, in pediatrics, and in that context, we'll be looking at Crohn's disease. So looking at how children with Crohn's disease are going to respond to biologics. So the medication which has a very high failure rate, if you could identify which of these patients will actually have remission, that could obviously inform what kind of therapy they could be given at a very early age. So again, so we have two groups of patients. We have the patients who had active inflammation throughout their disease course versus the patients who actually went into remission. And you can again see very distinctive signatures between the patients who are in remission versus those who are active. And then if we were to take the clinical or the serum markers, that is this set of bars over here, they actually don't perform as well. Whereas our radiomic features actually do validate across multiple institutions, which is why we have 2 bars over here, and the performance is fairly reasonable for this fairly difficult problem. So we've spoken a lot about different types of patterns, different types of features, different types of models that we can use to extract these things. But one aspect of when you are trying to find a hidden signature is how do you know whether what you've actually found is a signature that you care about? So how do you actually interpret the signature as actually having some clinical biological meaning, in other words? So what this means is, for example, if we get a result, do we have any idea why that result is what it is? So what does it mean in the context of medical imaging data? So for example, this is a rectal MRI scan. I've kind of annotated some regions based on what the radiologist told me about. And the question is, what are these? They said, well, I can see some contrast differences, but it's a very hard question for them to exactly define. They knew that this blue region was fat. They suspected that this red region might be fibrosis, but they said this might be something to do with mucosa. But the rest of it, they weren't very clear about what they said. Like, there is something there, but I can't be sure about exactly what those things are, which is a big problem with visual interpretation fundamentally, right? But on the other hand, if we looked at the pathology data and we spoke to pathologists, they can actually give us a very detailed understanding of all of these different regions. They know what the fat, the fibrosis, the mucosa, the muscle. They can define these regions in a lot of detail. And so our kind of thesis or our kind of objective here is to try to connect the dots between these. So can we start to interpret all those pretty looking, interesting looking heat maps that I've been showing you so far to the underlying pathology or biology, so we can try to interpret what they mean and why they're working the way they do. So if we can do this, we can actually start to define better surrogates of tissue changes on imaging. So how would we do this? So this is actually a tool that we've released. Let me know if you guys don't see the video. Do you guys see the video?
Yeah, okay.
Great, awesome. So this is a tool we've released, which allows you to load in the MRI, the CT scan. It allows you to go in, manipulate it, scale it, rotate it, make any basic fixes that you need to make to the image to try and figure out what's going on. And then once you've done that, it allows you to go in and actually place landmarks between the two modalities. So this would be something that we would need a clinical expert to help us with. But where the colors correspond to landmarks on the two modalities, you can see how they're able to go in and place it. This is happening essentially real time. It's a recording of a real time landmark placement. And you can actually go back in, edit the landmarks if you need to. You can update them and so on and forth. And then it can very quickly generate or run the registration to actually line the landmarks up. So it's taking those landmarks and warping them into alignment. So now you're able to overlay the pathology image onto the MRI. So you're able to get this much more detailed visualization and mapping from pathology onto MRI. Once you have this, you can start to relate this to the underlying signatures that you've been generating using machine deep learning or radiomics approaches. So one of the ways we've used this kind of analysis in the context of Crohn's disease. So this was a cohort of patients who had stricturing Crohn's disease. So they have a stricture which has been taken out from for which the patient has undergone surgery. And so we get a pathology specimen. We have the pre-surgical imaging. So that's what the radiology image looks like. And then what that allows us to do is use this pathology to define phenotypes on the imaging. So we're able to go in and start to look at radiomic signatures which distinguish between inflammation in terms of low and high severity. So we took the pathology scan, worked out what is high severity and low severity, and used that to define the radiomic features which best distinguish between low and high inflammation. Interestingly enough, so we also did this where we had a radiologist go in and score these scans for inflammation as well. And then what we found that was interesting is that the radiologist and the radiomics kind of performed equivalent to each other in a way, but integrating them provided the best overall performance in identifying severe inflammation in these structuring patients. And then we have similar results in the context of fibrosis as well. So we have so that's one way we managed to use it. A different way that we can think about using it is what happens if we start to map these onto each other, right? So if we were to take, so this is the heat map I showed you. I said radiomics, low heterogeneity, high heterogeneity, and so on and forth. We take this data and then we're able to overlay pathology image with all of its annotations onto it. And one of the things we noticed is there is a kind of correspondence in the way the pathology images, the pathology data, the regions on the pathology seem to correspond to the regions on the imaging. So if we could use this information to actually drive what partitions, what regions are present, that could allow us to start to go beyond just looking at the heterogeneity, but start to look at the organization potentially of these maps, their connections and so on and forth, and actually map and understand what might be driving imaging signatures from a pathology perspective. So we took the image, we partitioned it, we built some signatures to try and identify the interactions between regions. And one of the things we found was when we did this, we were actually able to understand. So if we took those, so essentially this heat map over here, you can see there's a lot of red, green, and blue. That gets partitioned essentially into a low, medium, and high expression. So low over here is denoted by blue, intermediate is yellow, and then high is red. So once we do that, we take the low, medium, and high, and we take those signatures. And what we found was that those signatures can map onto pathology. And when we do that, we found that the underlying pathologic tissue region that is driving those signatures is actually quite different. So red regions tended to overlap with tumor. Blue regions tended to overlap with fibrosis, which is kind of a treatment effect. And there was a significant difference between patients, between the signatures between these two regions. But more interestingly, we took these signatures, we actually found that the distributions were very different between the patients who had residual disease, had metastatic disease, versus those who did not. You can see how the patients who had metastatic disease, a lot more interactions primarily with the tumor, whereas the patients who had response, who actually had good response, had very small regions of residual tumor, complete responders tended to have a lot more interaction with the fibrosis, because the fibrosis was showing up in those patients a lot more than it was showing up in the patients who did not have response. So this is an interesting approach where we're actually able to map between them and use that to understand what might be driving our signatures. But we can go beyond that. We can start to look at, okay, what other types of information can we start to extract from the imaging? So, for example, we have patients who have, partial response. They tend to have these very discontinuous kind of structures in their images. So what we did is we said, okay, let's take these patients. Let's try to build kind of a map to understand how the tumor and the regions are changing as a result of treatment. So usually when we're talking to an oncologist or radiologist, they're explaining to us about how when a patient has been treated successfully, the tumor has shrunk, right? Or in other cases, they're like, well, the tumor is kind of growing aggressively. So this kind of idea of growing, shrinking kind of suggests that there may be deformations at play. So we came up with a framework to try and quantify these deformations. So here, this heat map is actually, tiny arrows indicating how the regions are deforming as a result of the tumor. We can take this information and start to extract measurements from it. So we can look at how much deformation there is. We can look at what ways is going inward, outward, and so on. And that gives us different types of measurements and features. So once we have these features of kind of a very hidden aspect of the deformation within the image, we can actually look at how that is different between patients who had response, complete response, versus patients who had very poor response. So complete responders tend to have not a lot of deformation, very regular, going only in one direction, whereas non-responders seem to have these very heterogeneous deformations, which are very chaotic, going inward, outward, and so on and forth. And what we found was these are significantly different between patients who did and did not have response. And more interestingly, combining this information with kind of the appearance of the region actually gave us a significantly improved, both across discovery and validation, significantly improved performance in distinguishing between response groups. This was some work that just came out in NPJ Precision Oncology over the summer. So this is very exciting. This suggests that we are actually able to identify interesting new signatures. But now if we take these signatures, we actually said, okay, is there a way for actually start to identify if these signatures work in kind of more clinical specific settings? So we actually got access to a clinical trial data set. So this is kind of a unique, it's a single arm clinical trial data set where they were testing out immune checkpoint inhibitors together with the chemoradiation that is routinely given. So very detailed neoadjuvant therapy. What we were trying to understand is, can we actually assess which patients are going to benefit from getting all of the different components versus getting only one of the components, and so on and so forth. So when we looked at this kind of this signature, which is 15 days after the initiation of the immune checkpoint inhibitors, what we found was a very different signatures, even at this very early time point of the response to treatment. So you can see over here, patient who responded versus patient who did not respond. And then they actually map to very distinct clusters in kind of a latent space. And then that latent space actually allows you to identify the responders and non-responders, even at this point, with up to 75% accuracy, which is pretty cool, given that it's so early in their treatment timeline. We were also able to use this data to correlate it with the underlying pathology to identify what features might be driving the signature. What we found over here, though, was interesting to me, which was that the deformation features actually did not correspond to specific biology, whereas the texture, the heterogeneity features did. You can see over here with the stars. And I think that might be because the deformation is actually capturing more of a structural aspect of the tumor, whereas the heterogeneity is capturing the underlying biology of the tumor. So this kind of starts to get us towards understanding and interpreting better what the features, the measurements are that we've been extracting. So great. So we've spoken a lot. We try to give you an idea about interpretability, but the last piece to this puzzle is the question of generalizability. So how do we make sure that the models actually know what they're capturing and are going to consider and are going to do it consistently, right? So we don't want the dog robots to not be able to find cats or vice versa. We want to make sure that they're able to generalize across populations, across institutions, across different subtypes, and so on and forth. So one of the ways I realized this is this, this is a review paper from a couple of years ago. So this was a very interesting paper to me because when you look at it, the paper has a lot of detail. It's a large meta review of deep learning versus healthcare professionals. And what I found interesting is they had this statement right here in the abstract, which said the diagnostic performance of deep learning models is equivalent to healthcare professionals. Okay, great. So we're able to build models that work really well, but very few of them presented externally validated result or compared the performance on the same samples between the two models. What does this mean? What does it mean that they've not actually done this? Well, this here is real data from my lab. I'm going to bring it back in a little bit and I'll explain it a little bit more. But what this means is very often we will build a model in a training set that has a very high accuracy, like 82% accuracy, and then we will take that exact same model to a different cohort, a different institution, different data set, and the performance completely breaks down. So we've gone from an 80% accuracy to a 50% accuracy. And this, of course, is a major problem. This is the kind of problem that we saw a little bit about even during COVID, where we said, oh, we found these AI models very accurate in the lab, and you go to real life and then they don't really work. You're trying to understand what's going on. It turns out the model may not actually be looking at what is relevant for making a decision. So how do we actually ensure the generalizability of these AI models? So this is kind of a general pipeline of how it works to build AI models generally, and even especially in the medical domain. So you get data, you prepare it, you train a model, you test the model, and then you kind of improve it, iterate on it to get better performance. Turns out each of these steps are where we could be starting to look at how models might fail, how models could be enabled to succeed, so on and so forth. So let's start with the first ones. We have cleaning, preparing, and manipulating the data. So towards this, the question is, what are the sources of error in my data set? And so for this, we've actually released a package. So this is a quality control package for radiology data. It can be used for MRI or CT scans, and allows you to very quickly check the quality of large cohorts. And completely can be done completely offline and can be run, can be run on my laptop, 30 seconds a scan. So this is just kind of a visualization of the interface. So you load the data, it creates this tab separated value file, which has all of this information on it. So it has the different, it has tables of all of the different measurements, the metadata, the noise measurements it's extracting. It's completely interactive. It highlights throughout the interface as you go through it. And this is just a locally hosted web page. And then you're able to look at the trends in the data. So here you can see for SNR3, you can see how all of them have kind of, there's a little bit of noise, here and there. And then, but if you picked a different scan, if you picked a different measurement, you might actually start to find those outliers, which have very different. So for example, over here, the CPP for this patient would be extremely high, which would suggest that that's an outlier. It allows you to go in and identify which scans need to be evaluated and corrected in what fashion. And this is actually some work that we recently got funded to expand and make available in larger, in a dashboard form to the community through UO1 from the NCI. So we can fix the underlying data. We can try to process the images, but then even if we process all of those images, there are still lots of differences between scans. So for example, you could have different scanners, you could have different magnetic strengths or dose strengths, you could have different resolutions, you could have different imaging parameters, the reconstruction algorithm in CT, the TR, the echo repetition times in an MRI. So how do we actually see if these radiomics, these deep learning models are robust to these kinds of changes? So this, I'm going to bring back that graph that I showed you earlier. This is actually a real study that we conducted. It taught us a lot about these ideas of resiliency and generalizability. So here, the left D1 is the training cohort, D2 is the validation cohort. The top row are patients who were healthy. The bottom row are patients who had disease. And you can see over here, if you look at these signatures, the top row, you can see how it's blue for healthy and red for disease. And then we go to the validation set and it's exactly inverted. So now healthy is red, blue is diseased. So as you can also see that in the violin plots, you take this data, you run it through a model, turns out you trained on this data set, tested on this data set, because all the trends inverted, the model performance is completely tanked. So why does this happen? Well, it turns out that there are actually many things to think about. So, one idea is the concept that we've been thinking a lot about how good a feature is, so how accurate, how high the AUC is, which is on one axis, but on the other axis is the generalizability of the model. So how reproducible is it? How consistent is this feature? So what you would like is, you would like features which are in this quadrant, which have very high accuracy and are also more reproducible, and you ideally want to get rid of as many features as possible from this quadrant, which are not very reproducible and are also not very accurate, right? So if you were actually able to do this, then you could actually go in and probably build more accurate, more generalizable models. So how did that work? Well, we actually discovered that it's not just one source of parameters which tends to drive this particular aspect. Each aspect of the way the image is acquired can cause a different level of noise or variability in the image, and so you have to systematically go in and remove each source of variation to get a set of features that are actually consistent. Once you do that, though, you start to find features which actually generalize between the training and validation sets. So here you can see the same patterns between the healthy patients across training and validation, and similarly the same patterns in the disease patients between training and validation. Correspondingly in the violin plots, and then of course in the classifier results, you can see the orange bar, we were at 80%, and we stay at 80% even after we test the model, which is what we would like to achieve, because that's actually going to ensure that the model works. So this required us to go in, benchmark a whole host of features, figure out what's going on. But then the question is, okay, how do I know, what is a reproducible feature? Like, where is a cutoff for the reproducible feature? And towards this, we actually developed a new machine learning model that is able to use that as a constraint within the model. We said, why should we pick what is a reproducible feature? Let the model decide what is a reproducible feature, and how that interplays. Like I said, there's a trade-off between reproducibility and between discriminability and reproducibility. So this here is kind of a machine learning setup. So you have the discriminability term over here. This, we've added in this new term for capturing the reproducibility or the variability of the model, and this is a constraint to make sure we're using the minimum feature set. It's kind of an adaptation of the popular lasso algorithm in machine learning. So we take this, and what we actually found is that if we take these constraints, balancing the constraint of variability and discriminability kind of gives you the best overall performance. So the red bar over here is our new variability regularized feature selection, which is incorporating both reproducibility and variability into a single cost function. And then these other bars correspond to other feature selection schemes. And we actually tested those feature selection schemes with and without the whole variability aspect being built into it. And actually turned out that our the machine learning model that we're proposing here performs a lot better, potentially because it's not just making an arbitrary cutoff of where a feature is reproducible or not. It's actually going in and potentially picking some features which are marginally not reproducible, but are still very discriminable and maybe assisting the model in its performance. And we also analyzed what features there were. We found that the VARFS model is actually capturing features from all the other feature types that we have. So that kind of gives us confidence that we are picking kind of the best of all worlds when we build this data model. And then finally, I'm just going to briefly touch on the work that Lima alluded to during the introduction, which is what we just presented at MICAI last month. So this is the idea of, okay, we're looking at reproducibility, generalizability across institutions. Can we also use this approach to try and build generalizability across populations? So what this means is, so for example, you have an input MRI scan, you train a model, you learn a representation, you have a loss function to learn that representation. As part of the network, you have BRAP propagation. This is kind of the standard approach used for any deep learning or even a machine learning model. Is kind of the same idea. You take a model and you kind of get BRAP propagation to optimize it. And what our framework that we proposed at MICAI was trying to use this framework and adapt it to account for what are known as sensitive attributes. These are the attributes which are kind of population-related attributes. So, for example, it could be the race, the gender of the patient, and so on and so forth. How do we make sure that the sensitive attribute is part of this whole equation? And what we propose is to essentially augment the cross-entropy loss that we're using over here to build a good model with a mutual information loss, so that we're minimizing the mutual information between the learned representation and the sensitive attribute. So if these two are disconnected, then it's going to be a much more effective model, is kind of the hypothesis over here. And the way we did this, we actually implemented a new score function difference to be able to more accurately estimate the mutual information and more, also in a computationally tractable fashion, because mutual information is a very complex loss function to actually optimize for. And the way this is going to work is, so we have our two variables over here. So we have the actual representation. This is the sensitive attribute. The green is the actual learned representation. The red is the entropy, the information content between them. And using mutual information, we want to try and minimize this as much as possible. And through this optimization process, it actually starts to minimize these two, so that the two is the representation and the attributes are now independent of each other. So how do these results work? So we actually tested it in a few different disease cases. I'm going to present some of the data on the rectal cancer front. And what this is so on the left over here, we have kind of a latent space representation of what we call, so this is the fairness-aware mutual information, and that can be used in conjunction with different machine learning models. So here we used it with a vision transformer. So this is kind of the latent space that we get from our proposed approach, the FAMI approach as we called it. And this is the latent space that we get from the vision transformer as it is, without accounting for sensitive attributes. In this case, the sensitive attribute was gender, the patient was male or female. So what we find over here is that in each case, the model, in both cases we have separability, but the FAMI approach appears to give us a little bit better separability. And then the other thing we see is that in the case of the VIT by itself, it seems to kind of primarily put the genders are not equally distributed between the two cohorts, whereas over here you can see that the FAMI approach has actually yielded at a representation where you have a reasonable representation of both genders in both clusters, suggesting that we've actually taken that factor out as a predictive part of our model. So if we further tested that, so if we compare the FAMI model to the VIT by itself, the vanilla VIT without any information about the sensitive attributes, we actually see that FAMI yields a much higher AUC in terms of identifying complete responders. If we compare that to some alternatives that we can implement together with VIT for enabling fairness, we see that FAMI actually improves over them as well. And then, of course, if we use alternatives to computing the mutual information, our particular implementation was a lot more efficient as well as a lot more accurate in estimating the mutual information. So this, again, shows that we're able to extract the hidden signature and then actually use it to build a much more generalizable, much more accurate model as well. So with that, I'm going to bring my talk to a wrap. So we've spoken a lot about computational imaging, about disease assessment, about how we can enable more interpretable AI markers for predicting, prognosticating, assessing response, and then evaluating the generalizability of these predictors to minimize the impact of variations, as well as ensure their performance across different populations and allow us to actually extract the hidden signatures that are the most relevant for our for a particular task at hand. Of course, all of the work that I mentioned over here is work that has been accomplished by the stellar researchers in my group. So this is all of us here together. As I like to say, they make all of the magic happen, and I just get to stand here and tell you all about it. I'd like to acknowledge all of the funding agencies that we've been fortunate to get funded from. I have a QR code for our the tools that we've released open source from our lab, and of course, I'm happy to also follow up over email for those of you who would like to connect with me like that. And with that, I'll end my talk. Thank you so much for your attention.
Yeah, thank you so much, Satish. It was very interesting and a very insightful talk, for sure. Yeah. Do anyone have any questions? You can just unmute yourself and go ahead and ask questions.
I have a question.
Go ahead.
Yeah, it's Satish. It's a interesting talk. I have one question. You were mentioning about the targeted tissue pathology using AI models. What about the management states? Like, how do you track cells which are uh, like migrating from the target to the distant tissues? So, are there any tools like AI tools that you are working on that can figure out the maladies?
So if I understand the question correctly, the question is: are we able to? Do we have any ideas, or are we able to do anything with the migrating cells, which are kind of moving from the tumor to other areas. Is that right?
Right.
Yeah, that's a great question. So the fact is that if we want to try to analyze that kind of phenotype of the cell, what we essentially need is we need to essentially remember that all of these are images and slides taken at a particular point in time, right? So what that would need is we would actually need to either be imaging probably in an in vitro or maybe in some kind of in vivo setting. We would need to be kind of doing analysis of cell migration. Alternatively, we would need to actually have multiple samples to be able to say, oh, we're able to now see the cells here, and now when we change it, now the cells have kind of changed to this formation, and or we'd have to use some kind of novel imaging agent to try and tag the cells and so on and so forth. So that's not quite something we've gotten into yet. We recently got funded through the NIH to develop some of these tools in the preclinical space, where we will be trying to develop tools that are able to identify specific aspects of inflammation, of fibrosis, using kind of these novel imaging modalities in the context of IBD as well as graft versus host disease, GVHD. So I suspect over there we'd be able to start to do this, because the catch is clinically it's going to be very hard to try and find migrating cells, right? So you'd have to analyze it in a much more controlled setting. Another way to think of it is, of course, we could start to look at, kind of the dynamics of the microenvironment. So is there a way for us to potentially look at the evolution of treatment response by getting samples from different patients at different points in time? And that's also something we're exploring in other studies, where we're looking at, okay, is there a way for us to actually look at transcriptomic changes, look at the evolution of certain signatures over time, so that we can understand what might be driving, what best predicts the outcome for these patients, and what can we discover as far as the tumor biology goes. Because again, that's, in many cases, even the tumor biology is unknown. So we're kind of, we have the opportunity to actually discover new phenotypes as a result. So hopefully that answers the question a little bit.
Thank you, Satish. But also actually one more question.
Sure.
How do you consider comorbidities in using AI and technologies in complex disease like cancers? People will have multiple problems like diabetes, hypertension, other associated problems. So will you be considering them also along with the AI and assessing the structural changes in the tumors or cancers?
Yeah, so that's
What's
a good
thought?
Yeah, that's an interesting thing. That's an interesting point to think about. So the question is, how do we have a way to account for, or have we worked on anything to do with the comorbidities in these patients? So there are kind of two ways I can think of this, right? So one is, there is comorbidities could be considered kind of a sensitive attribute in a way, right? So to go back to that last study that I presented, where we're looking at how the signatures generalize across populations, you could think of the populations as patients who have comorbidities and those who don't. And ideally, you want the imaging signature to kind of be separate from the comorbidity. You don't want it to predict what a comorbidity can predict already, right? So one way we're going to be looking at this is actually to look at, okay, can we use this model to try and build more independent signatures, if you will. The other way is, can we actually identify the patients who are at high risk of comorbidities? And this is some of the work we're doing in the context of Crohn's and so on. So when we're trying to identify those patients with severe disease, with severe inflammation, severe fibrosis, we're essentially identifying the patients who have the highest risk of developing other comorbidities and end up having much worse outcomes as a result. So that's kind of the next phase of some of this work is actually going to be trying to connect back to the clinical timeline and outcomes for these patients, so we can actually apply the signature in a clinical context and see how it can be used to inform their decisions there.
Thank you so much, Dr. Satish. Thank you so much.
Yeah, thank you.
Does anyone have any questions? Okay. Yeah, I have just one question, sir. I mean, I don't want to take much of your time. It's already just a minute more. Since you mentioned about foundational models, right? I was just curious. did you take a look at the embeddings and the vector space from there and compare to the radiomics that you're actually extracting? So is there any work already done, or are you planning to do anything with it?
So we are very actively working on different aspects of foundation models. So the work I showed you here is just kind of that was kind of our entry point into the space. So right now we're trying to figure out. So the interesting thing about foundation models just to remind everyone, foundation models are essentially these very large kind of abstracted representations of at this point, from the healthcare perspective, a lot of them are in the medical imaging domain, where you essentially take millions of images of slides or MRIs or associated text description and are able to build a very abstracted latent space, as they call it, like a space where you're able to understand, which not able to understand necessarily, but you're able to use that space to then identify phenotypes, characterize aspects of the disease, which in other cases you might have had to build a data set for each disease. So essentially it is able to exploit the information that is common across a whole host of different types of data to identify representations that can actually be used to characterize the disease or predict outcomes in a very effective fashion, right? And there's been a lot of recent work showing that these models, especially a lot of pathology models, are actually very accurate in a few different tasks. And we're actually working on a few different aspects of foundation models. There are multiple questions that still remain. So to me, for example, one of the big questions is, so like we showed with combining like a MedSam, which is kind of one type of foundation model, with kind of a specialized deep learning model, is there a way for us to actually combine these models, right? So can we actually start to exploit the advantages of both? Because to me, radiomics, deep learning, foundation models, they're all essentially different tools in our arsenal. And the question is, how do we start to put those tools together to get the best result that we can get, right? So the short answer is we're exploring it in a lot of detail. The longer answer is that we're trying to understand how best to extract information that can be exploited in conjunction with the other information we have available. We already know that there is a latent space representation that is abstracted, that is capturing some aspect of the disease, but is not capturing the entirety of the disease because the model has some limitations in its performance. So now can we kind of augment it with what we know about the disease or what specific characteristics we've already identified for these diseases?
That's great. Yeah. I don't. I have more questions, but I'll follow up with you over the email. But yeah. So yeah, thank you so much for joining and taking time to give us this interesting, impactful talk. Thanks everyone for joining us, and yes, thank you so much, Satish. Yeah.
Thank you, guys. Feel free to reach out to me over email or LinkedIn or whatever if any more questions. Thank you so much.